So if the doctor determines that you have a significant narrowing of one of your arteries or more than one artery, then the question is that what does the evidence for you to benefit from a procedure? So if you look at the current guidelines and the current evidence, if you have a narrowing that involves the center artery, as I call it, or the more technical name would be left anterior descending artery, especially the proximal part of it, then generally the guidelines will suggest that you will be better off having a revascularization procedure, be it a stent or a bypass, compared to just purely taking medication. Now, if you have a branch that's blocked, you are probably no better off if you have a procedure vis-a-vis medication. In other words, you can treat it medically. Now, if you have all three major arteries significantly blocked, or even worse still with the left main artery narrow, then you are generally better off with a revascularization procedure rather than having a medication alone. Now, if you do not have any disease involving the left main or the proximal LAD or the LAD, and you just have disease involving either the right coronary artery or the left circumflex artery, then the question is that is it okay for the patient to take medication, or must the patient undergo a stenting procedure? So if you look at the current data, the patient is probably not worse off just purely taking medicine as compared to angioplasty. In other words, medical therapy is still a very good option if the patient refuses a procedure, if it's a circumflex or right coronary artery. So that is the current status as it is. So I think it's important for us to discuss this in the context of his condition, because all procedures carry a real risk. Because if you do a bypass, there's a real risk of stroke, there's a real risk of death. So we must make sure that patients benefit from it. Many patients do choose angioplasty or stenting. So the question now is that if, for example, having assessed everything and it's determined that the patient will benefit from a procedure and chooses stenting, then sometimes they ask the question, okay, if you do stenting, is there a difference between a stent that is so-called bioabsorbable, or the whole stent can be absorbed, or a standard stent where there is what we call drug coating on the metal? In our technical term we use it, we call it drug-eluting stent, or DES. Okay, the status of the stents as follows. So about 7 years ago, they started on this Absorb, which is a polymer-based stent, and they call it a scaffold, and it is absorbable. But eventually, this stent was withdrawn from some of the markets, primarily because there was data from some of the European centers that they had an increased risk of stent thrombosis, in other words, clotting of the vessels. But if you revisit the data and you attend the meetings where this is discussed in detail, actually the large majority of the patients did well. And the biggest benefit from it is that patients don't need long-term blood thinning agents. That is really the real benefit, because it is undoubtedly so that if patients continue on long-term blood thinners, then there is an increased risk of bleeding the brain and also bleeding from stomach or other organs. So these are real risks. In the recent years, there have been other developments of these absorbable stents, as I call them, and some of them are magnesium alloys, and they actually do very well because they have better radial strength, and again, at about 1 year's time, most of that metal is absorbed by the body, so you do not have any residual stent, which means that you do not need blood thinners. And the current data that's coming out from centers that are doing trials of these have showed very good results with these stents. So certainly I think bioabsorbable stents or scaffolds are here to stay. However, they do have certain limitations because of the size of the stents. Not all patients are suited for those stents because if the vessel is too big or too small, we don't have the sizes for those stents. Or if there is a lot of calcium in the walls, again, the patients may not be suited for those stents. But if there's minor calcification, it is still fine. So the other sort of stents would be called the drug-eluting stents. Now those stents, again, we have to look at what we call the thin strut stents, which is the newer generation stents, which they are roughly about 70-80 microns thickness in terms of thin struts. Vis-a-vis the older generation stents where the metal strut thickness could be 150 microns or more, much thicker struts. The good thing about the newer generation stents is that if you look at all the published data of the thin strut stents and what we call the OCT data, OCT is called optical coherence tomography, using light to measure the stents in the coronary arteries. The data shows that many of these thin strut stents, by between 6 months to 1 year, a lot of them would have more than 90% or 100% coverage of their stent struts by endothelium. So it's fully covered, which again means that it is fully covered, you could theoretically stop blood thinners as well, which means that if it's fully covered and the patients need to stop the blood thinners for whatever reason, maybe they need to go for an appendicectomy, they need to go for surgery, actually it's quite safe. So that is the evolution of stents. And again, what the results are like, really it depends on the centers, the operator, their experience and skills. So that is very much an individual choice, and I think it's important for those who need this treatment to find out the results from different centers. However, in summary, I think stenting is in high volume and centers with experienced doctors is really a very safe option with also quite good long-term results. Some doctors ask about bypass as compared to stenting. So a lot of patients also do not understand when you undergo coronary artery bypass graft surgery or open heart surgery, if the graft is from your artery, what we call the internal mammary artery, after 10 years, 90% of those grafts will do well. But if the grafts were taken from the leg veins, if you look at again the published literature now, after about 18 months, we are looking at about maybe 40% of these grafts would have been narrowed or occluded. So in other words, there are also limitations in terms of bypass graft surgery. So in discussing the options with the patients, it's important to help the patients understand the pros and cons of either option. With that, I think as we evolve, as we get newer and newer technologies in the equipment, in terms of the types of stents and the devices, I think these procedures will become safer with better long-term results.